Thank you, Sanjay. And I really would like to thank all of you for inviting me here today. And sorry for delaying your break. Just I have to go to the airport for for a talk in Boston tomorrow morning. So thank you so much. Over the years, really, I learned a lot from you, and I hope to continue our collaboration. As you may know, I accepted the position to lead the cardiothoracic at University of Virginia, and also to be the co-director of the service line for the system. It's a big responsibility I'm really looking forward to. And I know actually that we're going to continue to collaborate. So I know that this is not the end. So thank you all. What we're going to talk today is for the repair of the aortic arch, open versus endovascular, and how the landscape is changing. And we heard actually over the last hour how the landscape is changing in the transplantation arena. And all these are very, very exciting news. This is my disclosures. Again, I would like to thank Kathy, Angela, and Deborah for this kind invitation, great friends over the years. And I appreciate your friendship and your leadership. And they put together this wonderful EMOTI program. So everything that we're going to talk today is off-label because currently there's no any FDA-approved device available, endograft. So the question is, why do we care and why we have this in the agenda today? Is because the open techniques, as great as can be, still would have significant morbidity and mortality. And by acknowledging the emerging endovascular technology, we can offer some more minimally invasive alternatives to the high-risk patients who are unfitted for an open EMOTI repair. And all these are the different approaches that we have for the aortic arch surgery. Can be something relatively simple to something much more complicated. So over the years, and I'm working here for the last 15 years, is we moved actually from the femoral cannulation to the axillary and the anominate. We do anominate cannulation since early EMOTI 2010 or 11. We haven't used retrograde cerebral perfusion, at least for the last 15 years that I'm here. We always use antegrade cerebral perfusion for brain protection. And especially for the last decade, we're using bilateral antegrade perfusion. From profound hypothermia down to 18 degrees, we move to moderate hypothermia. And how we define moderate hypothermia, this is between 20 to 28 degrees. And of course, this is a wide range, but usually we are cooling down to 24 degrees. This is kind of the level of the highest level of the moderate hypothermia. Regarding the technique, there is different techniques, and this is more depends on the anatomy, island technique versus the Y-graft technique. And as you have seen over the last few months, we have used a lot, quite often, in addition to the elephant trunk, what we call the frozen elephant trunk, where there is a stent on the trunk that goes down into the descending thoracic EMOTI aorta. So regarding the cannulation EMOTI strategies, the ones that you are very, very familiar with and we have used is the axillary and the anominate EMOTI cannulation. Over the years, and this is actually something that we published a few years ago with regards to how we think when we're going to cannulate somebody with an aortic disease via median sternotomy. And this is from the primary repair as well as to the redo EMOTI operations and how we choose to go through the axillary versus EMOTI the anominate. Now, if the disease extends into the lesser curvature of the arch, so at that point, the repair is most commonly a hemi-arch repair or proximal arch repair as we talk. And this requires a brief period of hypothermic circulatory hemorrhagic arrest. And this can vary from 12 to 13 minutes up to maybe 30 minutes, and really depends on what is the situation. A straightforward case is not similar as if you're dealing with a type A dissection. So really depends, but nevertheless, hemiarch brief hypothermic arrest is less than when we do a total arch. So we started when we are, we have already the inflow via the axillary on the anominate artery. We started with the cooling, we are on bypass. And when we close to 23, 24, or 25 degrees Celsius, then the flows are going down to 1.5 liters, and we start what we call the antegrade cerebral perfusion hemorrhagic period. At that point, when we start this antegrade cerebral perfusion period, we are going through the unilateral side. We perfuse the unilateral side of the brain, the right side of the brain. And then, as you see there, after we have opened the aorta, then we place a cannula into the left common carotid artery to provide the bilateral antegrade cerebral perfusion. For your knowledge, you need to know that this is not something that all the aortic centers around the United States actually do, because some aortic experts have actually published their technique by just providing only unilateral antegrade, just with only the right side of the brain, not also the right and the left, and with actually pretty good results. But we have found that when the hypothermia and the circulatory arrest time is more prolonged, this is when the bilateral antegrade cerebral perfusion is actually more beneficial to the patient. So in case for the entire aortic arch involvement, then we need to do a total aortic arch replacement and not only hemiarch. And these are the different options. But with regards to the cannulation strategy, as well as to the way that we deal with the temperature management, as well as the cerebral perfusion management and the brain protection, this remains the same. So what are the other approaches in the current landscape and the way that is changing? So we have the hybrid or total endovascular hemorrhagic approach. Nikolai Volodos was the one that he did the first hybrid procedure, an Ukrainian surgeon, in 1991, when actually nothing was really available and we didn't have the knowledge that we have today, when he repaired a pseudoaneurysm in a 41-year-old female from a prior coarctation repair. And the way that he did that hybrid procedure at the time, and you have to think that that was even before he published in 1991, he used two parts delivery system, one coming from the chest and one coming from the groin. I had the privilege and the honor to meet him in Dr. Dietrich's meeting in Arizona in 2013, where he actually presented the follow-up of that patient that he did at the time in 1991. And he said that the patient was still was doing okay and the endoprosthesis was stable and unchanged. And there is a very beautiful and elegant report at the spring supplement in the Journal of Endovascular Therapy in 2013. After Nikolai Volodos' report, there is another report in 1999 in circulation from Japan, where they report their experience with the branch endograft technology. So this is what we have today in addition to the open repair that we mentioned before. We have the hybrid repairs. We have some alternative approaches that I'll show you where we use the current endovascular technology. We have the fenestrated grafts and the branch grafts, but again, nothing of these things are FDA approved specifically for the arch. So these are the different approaches here, the hybrid approaches. As you can see from Timothy Chatter on the left-hand side there, is extra anatomic bypasses, subclavian carotid, and then we place a stent, and the inflow comes from the anominate artery. Usually, these techniques are done when the fenestrated or the branch endografts are not available. This is an early ECMO study that comes from here that we did quite a few years ago, actually, it's funny, 10 years ago. Over a 6-year period, we had 29 patients. Mortality and stroke at the time was mortality and spinal cord injury was 7% with a stroke, major stroke 3.4%. That was, this was actually a high risk ECMO patients. And maybe some of you remember this case that was done about a decade ago, maybe actually a little more than a decade ago. And that was a patient that had a methacrylate plate for a fibrosarcoma in the chest. And he had it, this reconstruction. So because of the methacrylate plate, we couldn't really go through the median sternotomy. So we chose to use, to do a left posterolateral thoracotomy. So as an inflow, we used the descending thoracic aorta, then we constructed the bypass into the left subclavian artery. Then we moved to do left subclavian to carotid bypass, and then across left carotid to right carotid bypass, and then placing a stent across the arch. And this is how we solve that problem. And this is the CT of that patient as a follow-up. This is another of our cases where we did the bypasses on the neck. We landed the stent distal to the anominate, and then we use as an inflow in this case, of course, as an inflow is the anominate artery. Now, how we compare the open arch operation with the hybrid. Actually, this is a little difficult to compare. This is, we tried to do this a few years ago. We presented at the American Association for Thoracic Surgery in 2015, where we looked at 319 patients. The majority, of course, were like open repairs, but we did have the hybrid repairs, like the ones that I mentioned to you before. We have found that the mortality was quite similar in the overall cohort, but the total neurologic event was a little higher on the hybrid. Of course, this is the hybrid patients in this cohort was really what we call the high-risk patients. And when we did a propensity matching score, no major differences were found. I had the honor to be the guest editor 2 years ago on the, in 2 consecutive issues for the Thoracic Endovascular Solutions. And I had a lot of experts around the country actually contribute to this regarding the arch repair and again, thoracoabdominal repair and the ascending repair. This is from across the street from Marvin Atkins and Alan Lamsden, where they talk about the parallel grafts. So as you see there, this is technology. This is what I called before the alternative options when already we use for something the technology that we have on the cell, even though this is not approved by the FDA for this particular disease, but the technology exists. So we use these different grafts that goes into the head vessels, the stent cross head. But this, one of the issues with these techniques is the long-term durability. So this is existing technology. The advantage is that it's less expensive, and has been used for the thoracoabdominal arena with some acceptable results, but we don't know the long-term durability. Currently, this is approved actually relatively recently. We have used it here at Baylor St. Luke's. This is the only FDA branch endograft ECMO device today. And this is the different configurations that around the country, this device, as well as us, we have used. This is a case, a recent ECMO case last year, where the patient came with a type 3 aortic ECMO dissection and placed a stent graft. But in the follow-up CT, I saw that there is this this proximal ECMO endoleak. So went ahead and we actually placed was when the TB device just actually got approved by the FDA, and we end up extending ECMO proximally with a stent in the subclavian, and then we landed distal into the left common carotid ECMO artery. And that was a CT ECMO afterwards. That was in November 24, 2022. This is a case that also we did ECMO here. That was also part of the trial initially, where the patient had a prior Bental type 1 dissection. He had a TIFR for the residual dissection. And then we did the extra-anatomic bypass on the neck, and we placed the stents across by using again an inflow into the anominate artery. And you can see this diagrammatic representation with the bypasses and the stent and the stent across the arch and the inflow into the anominate. So again, there's no, these are the non-FDA approved devices used in other parts of the world. Some of them are actually in trial here. But again, in Europe and in Canada, they have used these branch and fenestrated endografts for quite a while, for many, many years, and as well as in Canada. This is a very interesting category that we're going to see more and more. These are patients that they have prior type A aortic dissection, and now the arch needs to be replaced. The advantage that these patients have regarding the endovascular technology is that the stent graft can actually launch proximally into a Dacron graft. And this is really an advantage because you can avoid the stent to land in a native aorta that can cause retrograde dissection. So as a conclusion, the replacement of the aortic arch has undergone a significant change. There's multiple cannulation ECMO strategies. The one that we think and we prefer doesn't mean that is the best one, but the one that we prefer and we have used is actually axillary, and definitely for the last decade or so, ECMO anominate. With regards to the temperature management, also these have changed ECMO over the years. We don't use anymore the profound hypothermia, even though still there's some centers around the country that they do use the hypothermia and going down 20 degrees. Usually we like to go around 24 degrees Celsius. And we have to acknowledge that the landscape is changing. You see all the new and exciting technology coming down the pipeline with the transplantation arena, and definitely there is very exciting news in the aortic arena in combination with the transcatheter ECMO valves. So multiple devices coming down the pipeline, knowing the various options is very, very important. And back to once, get your question, and to Glenn regarding if the perfusionist needs to be involved in the things that we do today. I completely agree, and I'm actually a very big proponent on that. I think you're part of the team, and your knowledge is imperative for the best patient care. So there's no question in my mind that you have to be and you have to have a seat on the table in all these meetings regarding the cardiovascular care of the patient. So thank you, and it is a privilege to be here. Hope to see you again next year.